great pleasure to introduce Jane Speight, who is a chartered psychologist with a PhD in health psychology from the Royal University of London. She leads a large and varied program of research in Australia and the UK, through which she aims to improve the quality of life of people living with diabetes and encourage healthcare professionals to better understand the impact of diabetes and its treatment in the individual, from the individual perspective. Dr. Hilton Shapiro qualified in South Africa in 1973 from the University of Cape Town. He has worked in general practice in Australia since 1979. He currently works as a full-time solo GP in Mascot, Sydney, and has been in practice since 1982. This morning's presentation, Hemoglobin A1C Reduction and Reduced Distress with Structured Self-Monitored Blood Glucose Results and the Australian Step It Up trial. Thank you.
This morning, I'm charged with talking about the findings of our Step It Up study, which was an Australian observational study. But really what I want to frame that in is the wider context of the real value of structured self-monitoring of blood glucose for people with type 2 diabetes. So I'm going to set the scene, looking at the evidence that's informing our current practice and why you might even be slightly ambivalent about using structured monitoring. You might be thinking, well, there doesn't seem to be any evidence from that. I've read the Cochrane Review. I've read a few things that have been coming out of Australia in the last couple of years around this issue. So I'm going to speak about those elephants in the room, first of all, and then go on to talking about structured monitoring itself, what it is, a little bit about how you do it, but I'm going to leave most of that to Hilton to speak about afterwards in a more practical sense. And I'm going to walk you through the findings of the STEP study in the US, which was a randomised controlled trial of structured self-monitoring, and then talk you through our more recent findings from our Australian observational study. So I suspect I don't... excuse me, it's a bit early. I suspect I don't really need to tell you what self-monitoring of blood glucose is, but I thought I really need an introductory slide, so why not? So I found this definition on Wikipedia, which I actually thought was quite good. It reveals individual patterns of blood glucose changes and helps in the planning of meals, activities, and at what time of day to take medications. And I think sometimes we forget that. We often focus on it just being a blood glucose result and it telling us what the number is and thinking that that's going to tell us whether the person's in, so-called poor control or good control and so on, without really realising that self-monitoring of blood glucose is all about what to do next. It informs the person with diabetes in particular, about whether it's safe to drive, whether they might need to get some physical activity, whether they might have eaten too much or the wrong kinds of foods and so on for their breakfast. So it really is providing us with lots of information about what to do next, and I think that that's a really key part of the definition. So as I mentioned, there has been a Cochrane Review. Are people familiar with the Cochrane Review in this area? Okay, so just to summarise that briefly, the Cochrane Review from 2012 summarised 12 randomised controlled trials that involved over 3,000 participants. Most of those trials were a fairly short-term follow-up of around 6 months, and they found that HbA1c was reduced by about 0.3%. So this is self-monitoring of blood glucose in people with type 2 diabetes who are not using insulin. So overall, amongst these 9 RCTs of 6-month follow-up, a 0.3% improvement. Not earth-shattering, and probably not what you'd call clinically significant either, but certainly statistically significant. 2 of the trials were of 12-month duration, so of longer-term follow-up, but neither of those found any significant difference for HbA1c. And the Cochrane Review went on to look at what we would refer to as psychological outcomes or patient-reported outcomes, and they looked at a range of things that had been examined in these trials, and their summary was that there was no overall effect on patient satisfaction, emotional well-being, or health-related quality of life. Indeed, they found that the costs were higher with SMBG and their overall conclusion was that the clinical benefit is limited. So you can imagine this sets the scene for many health professionals and many policymakers indeed, thinking, well, there's really not much to be derived from SMBG in this group. So coming on to the Australian context then, in the last couple of years, you'd probably be aware that the Pharmaceutical Benefits Advisory Committee has been reviewing medications for use in diabetes, and one of them has been a review of the blood glucose test strips. So they had 3 overall objectives for this review: to describe the use and patterns of use for SMBG among people with type 2 diabetes, to determine the clinical outcomes and benefits of HbA1, for example, of HbA1C, of SMBG, relative to HbA1C monitoring alone for people with type 2 diabetes who are not using insulin, and to consider the clinical criteria for eligibility for subsidised access to blood glucose test strips under the PBS and NDSS, the National Diabetes Services Scheme. Now, their call for submissions closed at the end of 2012. 33 submissions were received, most of which are actually published on the PBS website. You can go and have a look at any of those. And a draft report was submitted to the PBAC for comment and feedback in December 2012. Comments were invited in January of the following year, and the stakeholder consultation was held in February, and the review has not yet concluded. So 2 years later, we still don't have a conclusion to that particular review around the utility of SMBG in people with type 2 diabetes who are not using insulin. Now, I don't know what that says to you. To me, it says that potentially this is a minefield of conflicting information, and that the policymakers really haven't got a clear, definitive answer on this yet. Point 2 of the Australian context is the RACGP guidelines. I won't dwell on these too much. I'm sure you're all very familiar with them. The point that I'll take from the RACGP guidelines is that routine self-monitoring of blood glucose in low-risk patients who are using oral glucose-lowering drugs, with the exception of sulfonylureas, is not recommended. So we'll come back to that term routine shortly, because I think that's really what's key here. And most recently, in the last couple of weeks, you may be familiar with the Choosing Wisely recommendations that were launched, I think, at the beginning of May. Now, this Choosing Wisely is an initiative of MPS Medicine Wise in collaboration with the RACGP on this particular recommendation. So there were several recommendations in collaboration with other groups, and this is the only one that focuses on diabetes. So recommendation 3 says, don't advocate routine self-monitoring of blood glucose for people with type 2 diabetes who are on oral medication only. So again, the use of this word routine, and again, saying there really doesn't seem to be evidence for doing this in type 2 diabetes, so let's not do it, let's not waste money on it, let's choose wisely. So this is the detail of that recommendation, and hopefully you can read that on the screen. I'd like to point out a few things to you. First of all, this recommendation says that there is no evidence that self-monitoring of blood glucose affects patient satisfaction, general well-being, or health-related quality of life. Well, I can tell you actually there's plenty of evidence. There's evidence on both sides of this debate, and I don't have time this morning to go into the details of that, but I will come on to talk to you a little bit more about the structured monitoring side. But basically, with unstructured monitoring, people are left frustrated, they feel irritated by it, they don't really know what they're doing with it, and it can impact negatively on their well-being and their quality of life and their confidence in their self-care. But on the structured side, actually there's a reasonable amount of evidence to say if people are using structured self-monitoring that it actually improves their confidence and it improves their well-being, and it helps them to manage their diabetes. So to say that there's no evidence in this space is actually a bit of a misnomer. Secondly, it refers to a 2012 Australian review that says that SMBG may possibly reduce HbA1C levels by 0.25 to 0.3%, which is considered clinically insignificant. Now, that 2012 review is actually the review that was published, the draft review that was published on the PBS website as part of that government review of blood glucose test strips. That review has never been finalised and it's not published. It's certainly not in the peer-reviewed literature. So although its findings are based somewhat on the Cochrane review and so on, the review that this Choosing Wisely recommendation is referring to hasn't been peer-reviewed, has not been finalised, and it's not been published fully. They go on to say that SMBG actually increased hypoglycemia risk, although causation was uncertain. Well, I'm not sure how anyone can say that something increased without saying how that increased or what the causation was. So I find that a bit odd as well. Importantly, at the end of this recommendation, it says the Australian government is spending on test strips is $143 million in 2012. Now, this is actually a gross exaggeration of the amount of money that's being spent on SMBG in people with non-insulin treated type 2 diabetes. In fact, that group amounts to about a third of this total. So 35% of people using self-monitoring of blood glucose are people with non-insulin treated type 2 diabetes. The rest of that money is going on the use of SMBG in people with type 1 diabetes or type 2 diabetes who are using insulin. So yes, there is a huge amount of money being spent in this space, but it's certainly not 143 million that's being used in non-insulin treated type 2 diabetes. And the guideline in the middle here says, therefore, use HbA1C levels to guide therapy and promote lifestyle interventions regardless of diabetes control. So I'm not really sure what's meant there by using HbA1C to guide therapy regardless of the control. So that to me is a bit of an odd kind of recommendation. The part that I really like in here is one of the exceptions, which is possibly short-term education about diet influencing blood sugar. So amongst all of these recommendations, what they're actually saying is that there is a specific use for SMBG amongst people with non-insulin treated type 2 diabetes if it's for educational purposes to help people to understand how to manage their diabetes better, how to intervene with lifestyle or indeed with other medications. So this is the purpose which I think we should be focusing on, and this is really the nub of what's going on here, and the rest of it I think is a bit of smoke, to be honest. So I'll come on to talking about why I challenge the evidence from the Cochrane review and indeed from Choosing Wisely. This is a paper that we published at the end of 2013. My centre, the Australian Centre for Behavioural Research in Diabetes, did submit to that consultation from PBAC. And then we thought that we should actually publish on this too. So we published this paper in Current Medical Research and Opinion, literally challenging the evidence and the assumptions around SMBG in people with type 2 diabetes not using insulin. So if you'd like a copy of this paper, please feel free to email me or contact the team at Roche, and I'm sure we can get copies to you. To summarise this paper, and indeed to summarise the Cochrane review, the Cochrane review had 9 studies that looked at self-monitoring of blood glucose over 6 months. These studies varied widely in their inclusion criteria and in terms of their methodologies. For some, there were no instructions about when to monitor or how often to monitor, or it simply wasn't reported in the paper. So they did the study, but they didn't really tell us exactly what they'd told people about how to monitor their blood glucose. In terms of the studies that did refer to the frequency of blood glucose monitoring, it varied considerably from 4 times per month to 6 times per day, 7 times per week. This is a huge variation in terms of what people might be recommended to do to monitor their blood glucose levels. But usually what we saw when we looked at the detail of those studies was the frequency was usually insufficient for plotting and interpreting the blood glucose patterns. Some of the studies incorporated feedback and education to people with diabetes and others didn't. And what we found was that the unstructured or low-frequency monitoring precludes identification of patterns, and those were the studies where SMBG was not effective. If you looked at the studies where the frequency was reasonable, where it was possible to plot and interpret blood glucose patterns, here's where we might refer to these studies as involving structured self-monitoring. These studies showed reduced HbA1c, reduced diabetes-related distress, so a form of well-being specific to diabetes, and improved confidence in diabetes self-care. And in our paper, we also refer to the fact that there are other outcomes that are important other than HbA1c. So self-monitoring is important for hypoglycemia detection for those who are using some or all medications. It's important for confidence and self-efficacy, for diabetes-related distress, for satisfaction with treatment. It's important for helping people to understand the perceived severity of their condition, and also for weight, blood pressure and cholesterol as well. So there's lots of reasons why people might want to be monitoring their blood glucose levels besides just improving their HbA1c. So let's look then at what structured self-monitoring of blood glucose is. Is anyone in the room familiar with this at all? A couple of people. Is anyone using it? Okay. So this is the Accu-Chek 360 tool. This is available from Roche. And what you can see on this slide is, if I can use the clicker device, basically people plot their blood glucose levels. This is 7 times per day, so this is one day in purple, this is the second day in green, and this is the third day in orange, I think it is. And so you can see this is before breakfast, after breakfast, before lunch, after lunch, before dinner, after dinner, and then at bedtime. And so people write their blood glucose level up here and they plot it on the graph. So they put a little X in the box, and as soon as they've got a few X's, they can join up the lines, join the dots, and they start to see a pattern emerging. So whereas before on their meter they would just be looking at a number, and if they wrote it down in a diary they'd be looking at a number, what they're able to do here is to visualise the pattern. And what you can see is that in the yellow bar, this is the in-target range. And above the yellow bar, this is high blood glucose levels, and below is the hypoglycemia. So what this enables people to do for themselves and in conjunction with their health professionals is easily identify the hypoglycemia, easily identify the high blood glucose levels, and of course there are more of them on this chart than I've actually put circles round. Importantly, it's also enabling people to identify when it's in target, and I think that this is a really important thing. So we focus on the highs and the lows, we're focusing on what goes wrong for people with diabetes, but let's also focus on when it's going right for them and what they're managing to do to get that right, because a lot of people start really focusing and fixating on the highs and the lows, and they think it's terrible and it's all going wrong, and they get very frustrated with it. It's never what they want it to be. But there's plenty of times when it's actually exactly where they want it to be, and fixing on those times and identifying what's going on and how that's going well for people is actually really positive and very helpful to them. Also on this slide, it shows you a couple of other things that people can note on their structured monitoring, which includes their meal size, so whether that was small, medium or large, their activity level, which they rate on a scale of 1 to 5 from very low through to very high, and also their, as I mentioned, their blood glucose level. They can write it down here too. So this also gives the context for the blood glucose level itself. So how much food they ate. It's not giving us a lot of detail about what they ate, but it's helping them to recall, well, actually, it was probably quite a large meal, perhaps, that I ate, or a small one, and maybe that's why I ended up hypo a few hours later. It's also giving them an indication of their energy levels, which is quite important too. So people do this. They monitor their blood glucose levels 7 times a day for 3 days. They form this pattern analysis, and then they bring that back in to see their GP or their practice nurse or their diabetes educator, and you can have a discussion about what this pattern looks like, what it means, and what might need to be adjusted, what might need to be done differently. So, importantly, structured self-monitoring is more than random or even routine finger pricking. It's one step in a complex intervention. So, and I want to set that scene quite clearly, because I think with the Cochrane Review, what they've done and what a lot of other groups and policymakers have done is think about self-monitoring as though it's like taking a pill, as though the more monitoring you do, the more pills you take, the better it is. The more monitoring you do, the better the HbA1c results should be, and that's simply not the case. This is definitely about quality rather than quantity, and it's about what you do with the information. And importantly, that you need to make some decisions even before you go down the route of monitoring around certain things. So this is what's involved in structured monitoring, which is the key to its success. There's agreement between the person with diabetes and the healthcare professional. They sit together and they set some targets. They talk about what blood glucose monitoring is about and what their blood glucose targets might be. There's enthusiasm from the health professional for the value of self-monitoring of blood glucose. And we hear that time and time again from people with diabetes, that they don't even know why they're monitoring because their health professional's not even interested in it. When they bring in their diary or their meter, the health professional doesn't look at it, so what's the point? And they actually think they're doing it for you. And if you're not interested in it and if you're not enthusiastic about it, then they don't understand why they're doing it. Feedback is really important, so getting that feedback from the pattern analysis is really key, so that the person actually feels that you're engaged with their blood glucose monitoring, you're helping them to understand what it's all about, and that the effort that they're putting in for those 3 days is really relevant to improving their outcomes. It's also important that there's a plan for health professionals to be skilled in SMBG interpretation. So it's really important that you actually understand what's going on with the SMBG pattern, and that you are able to interpret this information if the person with diabetes can't do that for themselves. And obviously that takes a bit of practice for the person with diabetes. So there's some training involved for the person with diabetes as well about what blood glucose monitoring is all about, why it's important, what information it can provide, and everything to do with using the devices and plotting it and so on. And then crucially, this step is really important, how to intervene to improve blood glucose levels. There is absolutely no point in someone doing all of this if nothing is going to change, if there is no intervention to improve. So if you've already identified that someone has a higher HbA1c than optimal, and that they're going to go through this 3 days of structured monitoring, what's the action at the end of that? What are you going to recommend them? Are you going to recommend that they change their diet in some way, that they get a bit more physical activity? Perhaps you need to titrate their oral medications. Perhaps going on to insulin is the next step for these people. So there's all sorts of ways in which you or the person with diabetes might intervene around this, and there needs to be some plan about that. Then, of course, there needs to be action around that. And importantly, all of this combines to influence the motivation of the person with diabetes for doing all of this. So I would argue that structured self-monitoring isn't just about finger pricking, it's not about routine checking, it's certainly not about random checking of blood glucose. There are structured steps in this process, which is a collaboration between you and the person with diabetes to get the real value out of self-monitoring for them. So Bill Polonsky and colleagues in the US undertook a randomised controlled trial of this structured monitoring approach using the Accu-Chek 360 tool, and that's what I'd like to talk to you about next. So their findings were actually published in Diabetes Care, the US journal, in 2011. So these are the STEP study results. I won't go into the details of exactly what they did. I've talked to you through the intervention. It was a randomised controlled trial, and they followed people up for 12 months. They had an intervention group and they had an active control group who received slightly enhanced usual care. So this analysis on the screen shows you the intention to treat analysis for HbA1c. So what this is showing you in the line with the squares on it up here is the active control group. So they improved at about 6 months in terms of their HbA1c by about 0.9%. And then they maintained that level around there up to 12 months. The structured testing group, as they referred to it, actually improved further at 6 months and then sort of maintained around there, went up slightly at 12 months. And so at 12 months, you see a 0.3% difference between these two groups in terms of their HbA1c. Now, intention to treat basically means that you take all of the people who are randomised to the active control group, you take all of the people who were randomised to the intervention group, and you analyse their data as if they stayed true to those two groups. So the active controls just remained controls. They didn't do anything that you didn't expect them to do, and the intervention group actually did the intervention as you expected. Now, that's obviously not real life. It doesn't always work out like that. So they've also conducted a per-protocol analysis. And what this means is that they've looked, in terms of the intervention group, they've split that group into people who actually followed the intervention as intended versus people who were in that group but didn't necessarily do the intervention exactly as intended. And so what you see here, again, is this active control group. So this hasn't changed. This pattern is the same, with the active control group improving at 6 months and staying out to 12. But here in the dotted line with the outline triangles is the structured testing group that didn't adhere to the protocol. So in this group, you see less of an improvement in their HbA1c, and it goes back up to the same level as the control group by 12 months. Whereas here in the solid line with the solid triangle, you see the group that actually adhered to the protocol. They did the intervention exactly as intended, and their improvement in HbA1c is greater and stays similarly improved at 12 months. So what this shows us is that for those people who engaged with the intervention, who were motivated to do it, who did it well over the period of time, they get the greatest benefit from doing it, which is as you'd expect. And, sorry, importantly, what I should say there is that this difference here is actually 0.5%, which is a clinically significant finding as well as statistically significant. So that's really important finding in terms of the group's ability to reduce their long-term complications of diabetes. In terms of the effect on general emotional well-being, there was a significant improvement in both groups over time. And indeed, in the per-protocol analysis, they found that the structured testing group participants reported a greater improvement. So again, those people who actually did the intervention as intended saw a greater improvement in their general emotional well-being. Now, in a separate paper, but reporting on the same study, Larry Fisher and colleagues looked at confidence in diabetes self-care as a result of the structured testing approach. And again, they looked at the per-protocol analysis. And what you can see here is the active control group in the shaded squares, the group who were in the intervention group but didn't adhere to the protocol in the clear triangles, and then the shaded triangles, the black triangles, show you the group who actually adhered to the protocol. And so you can see quite clearly that those who actually did the intervention as intended had a greater improvement in their confidence in diabetes self-care. And this was significantly inversely associated with change in HbA1c. So the more the confidence grew in their self-care, the better their HbA1c was at the end. So the conclusions from the STEP study were that structured self-monitoring led to significantly greater reduction in HbA1c in both the intention to treat and the per-protocol analysis, greater in the per-protocol, as I've shown you. There was an improvement in emotional well-being in the per-protocol analysis, and there was improvement in confidence in diabetes self-care, which was associated with a greater reduction in the HbA1c. In addition, and I didn't have time to go into the details of this, so it's not shown, but in the structured testing group, the physicians initiated treatment significantly more aggressively and earlier than the active control group physicians. Now, some people would say, well, that's why you've got a result, is because they up-titrated, them onto insulin, or they increased their oral meds. Duh. Yeah, that's kind of what you want to see from structured self-monitoring, is that there is, something that gets acted upon, and indeed there is an action, and medications are increased if they need to be, so that the HbA1c comes down. So critics of SMBG would say, well, you don't really need that, you can do that with HbA1c, but I would argue that it's the detail of the structured self-monitoring that gives you that picture of how it can be done and what's really needed for the person. Importantly also, the structured testing group used significantly fewer blood glucose testing strips over the course of the trial, which points to the importance of quality over quantity. So you remember that I talked about it being 3 days of structured monitoring and seven checks per day. So that's just 21 checks. That's all that you as a health professional are asking the person with diabetes to do for 3 days in the week before they come to see you. So you're not asking them to monitor every day. You're not asking them to monitor every day for the whole year. They can do what they want to around this if they find it useful. But what you're actually asking them to do is just 21 checks. Now, if you do that 4 times a year before the quarterly visits, then you're asking for about 80 checks per year. Now, as we know, on average in Australia, people with non-insulin treated type 2 diabetes are using about 300 test strips a year, so almost 1 a day at the moment. Actually, we could reduce that by quite a lot by using structured self-monitoring, and it could probably be much more effective. So our question was, can Step It Up be, can that STEP study protocol be implemented in Australia? So we called our study Step It Up, which refers to the structured testing protocol, intensified treatment, updated protocol. So we aimed to examine the feasibility of implementing the original STEP protocol in Australian primary care practice. Our design was a 24-week multi-centre observational study. GPs in 22 practices were given an instructional DVD on how to do structured self-monitoring, and they trained their patients to use and interpret the 360-degree tool. So in the STEP study, there was training of the health professionals by people. This was, in forums like this with in-person training. In our study, we specifically used an instructional DVD because we thought, in terms of sustaining this in the real world, we haven't got all the resources to go out training everyone, but we can put it all on a DVD, and health professionals can use that as a learning tool. In our study, we looked at 136 adults with non-insulin treated type 2 diabetes. And importantly, we didn't have a control group, so everyone I'm going to talk to you about were in the intervention group. This is an observational study of what happens in real-life practice. So this was our procedure. We had visits 1, 2, 3 and 4 at weeks 0, 4, 12 and 24. There was an eligibility check, informed consent and so on. Training happened at visits 1 and 2. HbA1c was checked at weeks 0, 12 and 24, so 3 months and 6 months later. We asked people to complete some questionnaires, again at 0, 12 and 24 weeks. We updated the electronic clinical record form at all points during the study. Blood glucose meters were downloaded at visits 4, 12 and 24, the weeks 4, 12 and 24. And we also had data acquisition from the 360-degree tool that you've seen already. We looked at HbA1c, we looked at change in HbA1c. We didn't use a centralised assay. Again, we didn't have the resources to do that. So all we asked was that the health professionals involved requested that the HbA1c came from the same path lab for each individual, so that within people it was coming from the same source, so there was no contamination there. We looked at diabetes-related distress, the same score that Bill Polonsky and colleagues had looked at, the diabetes distress score. This is scored on a range from 1 to 6, and scores of more than 2 suggest moderate diabetes distress, and scores of more than 3 suggest high distress. So this is not depression, this is the distress that people experience about living with diabetes, about managing it day to day, about the frustrations that they feel, the guilt and anxiety that they feel when it gets off track, the worry that they have about the complications for the future, and so on. So this is not depression, this is distress. We also looked at secondary endpoints, which were the percentage of blood glucose values within target, 4 to 10 millimoles per litre, the percentage above target, and the percentage below target. Of the 136 participants involved, we lost 29 to follow-up. That's pretty standard for a study like this. 9 didn't follow the protocol and withdrew consent, 5 didn't follow the protocol, and 4 withdrew. So we had data for almost 100 participants at visits 3 or 4. Our participant characteristics are fairly typical of what you might expect of this group of people with type 2 diabetes not using insulin. Average age 62, overweight, BMI of 32. We had 37% women, 85% Caucasian, and starting HbA1C of 8.7%. I still work in old money, I don't know about you. If you want the new money, it's 72 millimoles per mole. And the diabetes-related distress on average was in the moderate range, so just slightly above moderate distress across the group. This slide shows you our primary outcomes, which were HbA1C. So this shows you that at baseline, people had an HbA1C of 8.7%. By 3 months, this had gone down to 7.7%, and by 12, it was 7.5%. So this is showing you that the HbA1C improved significantly across this group by 1.2%. Diabetes-related distress also reduced significantly, and in terms of the percentage of people who were reporting moderate diabetes distress, this decreased from around a third of participants to only 15% of participants by 6 months. So using structured self-monitoring actually reduces people's diabetes-related distress. On this slide, I'm showing you the secondary outcomes. So this is the percentage within target went up from 59% to 59% to 69%. This was statistically significant. Above target, the percentage reduced from 40 to 30%. Again, this is statistically significant. And the percentage below target went from 0.3 to 0.4%. So no significant difference there, but we wouldn't expect or want to see an increase in hypoglycemia either. So our conclusions are that STEP is feasible in real-life primary care practice in Australia, supported by primary care clinicians. Structured monitoring is associated with significant reductions at 24 weeks in both HbA1C without increasing hypos and in diabetes-related distress. Note that our study was observational, so we had no control group. So this is a massive improvement in HbA1C that we've seen of 1.2%. Now, if you'll remember back to the US study, there was also a big improvement in the intervention group who adhered to the protocol, and that was also 1.2%. But their active control group also improved around 0.9%. So to look at our findings in a more conservative way, you might say, well, if we had a control group as well, we might also expect to see that control group improve because they got greater attention during the study. And so if you look at those differences between the two groups, you see an improvement of a difference between groups of around 0.3%. And I think that's a much more conservative way of looking at our findings and still showing that there is benefit to using this approach. So our findings support the US and European evidence that structured self-monitoring of blood glucose can improve both biomedical and psychological outcomes for adults with non-insulin treated type 2 diabetes. So finally, coming back to the choosing wisely recommendations, which were don't advocate routine self-monitoring for people with type 2 diabetes using oral medications, I suggest we change that and we talk about advocating. Let's talk about positive things here. Let's advocate structured self-monitoring of blood glucose for all people with non-insulin treated type 2 diabetes. Thanks very much. I'll be happy to take some questions, but we're going to move on to Hilton now, and we'll both take some questions at the end. Thank you.
Just by way of introduction, I run a solo practice in Mascot, Sydney, approximately 4 kilometres from the airport, but I'm in the commercial area of Mascot. I've been in that practice over 30 years. As all of you know, as time goes on, the patients get older, I suppose, the doctor gets older, but over and above that, we all accept, not only here in Australia but internationally, the incidence of diabetes, certainly type 2 diabetes, is growing exponentially. So I became interested in self-monitoring probably in the early 2000s when I was introduced to some of the earlier Roche tools and found that it worked very, very well. I could engage very well with my patients. And subsequently, as Roche developed more sophisticated, specifically computer tools, I took up with that. It also coincided with my transition from a paper-based record system to a computer-based system. So, I'm a solo GP, 33 years, same practice, age 60 plus. We applied Darwin's theory of evolution. It makes me a GP's dinosaur. Okay, a lot of what I'm going to say, Jane has already presented very eloquently, so I suppose I'm just going to reinforce a lot of her things. I'd like to be able to give you a few other practical approaches to SMBG, how I use it in my practice, and I've actually got case studies from my own patients. I keep all my SMBGs in a specific area and I can look at them at any time. So, as Jane said, we engage patients in diabetes self-management. I think this is very important. The structured self-monitoring is the tool that draws you, that your patient and you work together. And without it, I think patients are lost, and I think physicians many times are lost as well, where they're going with that patient. It provides a very useful framework for clinical decision-making if you use it in the correct way, and certainly optimizes that time you spend with the patient. And as I said, we will provide you with some studies that I've done with my own patients. When I think of diabetes, I think of numbers. And when we think of numbers, there are lots of them in diabetes. And I don't think this list is necessarily exhaustive, but here are all the numbers. But obviously, for our talk today, the numbers that are most important are the actual glucose numbers. So, as I said, computers came certainly into my practice in the mid to late 90s, and computers and numbers work very, very well. And combined with good software, I think you've got a marriage made in heaven. HbA1C alone is inadequate for assessing glycemic control and to identify, among others, postprandial hyperglycemia. Structured, notice I've got the word in italics, is essential to complement. We don't say get rid of HbA1C, to complement HbA1C in assessing glycemic control. So, talk about structured testing. Testing at the right frequency, the right times, and the right situations. And as a result, we generate very valuable information for ourselves as practitioners and for our patients. So why don't patients self-monitor? I think Jane has touched on this, but we'll go over it again. Patients lack specific instructions of how and when to test. Cost prohibitive, fortunately in Australia up till now, it hasn't been a major factor, but certainly in countries around the world, both first world and third world, it is an issue. The discomfort and inconvenience of pricking one's finger. Patients don't feel they need to test. They're feeling well. Hyperglycemia are very often asymptomatic. And as we've said, they do get that information and don't know what to do with it. And worse still, healthcare provider does not review and discuss those numbers with them. Clinicians, why don't we self-monitor? Well, patients sometimes don't arrive with their logbook or the meter. Patient doesn't adhere to any specific routine. This is the big issue, as you all know, private general practice, time. I think a lot of healthcare professionals don't know how to interpret it, having not been taught on using structured self-monitoring. And again, once again, we've got limited discussion, limited interaction. And then we have this wonderful phrase of treatment inertia. So we've got this unrealized potential, patients collecting their data, clinicians not using it. I'm not going to spend too much time here because Jane's gone into this in quite depth, but 2012 was obviously a year where you had the Cochrane review and you also had a review in the BMJ by Pharma. Just to reiterate the outcome of the Cochrane review. And the governments claim that perhaps it's expensive. The issue of lower quality of life, increased depression, anxiety, well, I think Jane's managed to show us that that's not true. And once again, we come back to the RACGP and again have highlighted routine, because what is routine? We talk about structured. Routine is not necessarily structured. So, on the other side, knowledge is power. If you empower your patient by using SMBG, they very quickly pick up the fact that if they have, out of the blue, they have a mango, and they decide, wow, I had mango for lunch, and 2 hours later I had a much higher blood glucose versus when I had an apple the other day. That they learn something. They'll come back and they'll tell you that, and they feel empowered. And I believe that by using self-monitoring glucose in a structured way, we can, in fact, do a lot more with lifestyle intervention and not necessarily always up the dose or include another agent. And once again, it allows them to adhere to the recommendations, modify their food intake, maintain motivation. Motivation is very important in diabetes. It's a long illness. Once again, they see the results and they feel empowered and they therefore adhere to their treatment, and helps us implementing a more specific treat-to-target approach. And it gives, this is important, a real-time feedback. As Jane said, you can ask your patient to do a 3-day snapshot of 21 tests a week before they see you. Yes, you'll have the HbA1C, but that's telling us about 100 days on average what's going on. But that 3-day snapshot is really live, and it's as it's happening now. That's what the patient's doing or what the patient isn't doing. And once again, I've referred in yellow to the positive studies from STEP and the Australian observational study under Jane. So, is that true? All you need is HbA1C, and I've said there's more to life than HbA1C. You're all aware that HbA1C does have falsely low readings due to those conditions, and then once again falsely elevated, for many conditions can interfere. So we ask ourselves a question, and we look at 2 patients, one in red, A, and the other one in blue, B, and that's a average daily glucose graph. And to me, both those graphs very different. So who's got the higher HbA1c? Okay, we can put some money on the bets, but let's go through it one by one. Patient A, as you can see, starts off with fasting hyperglycemia, goes up after breakfast, then goes quite low before lunch and dinner, spikes again after lunch, spikes again after dinner, and so we go. HbA1c is 7.8. What do you know? Patient B, different curve, very different. Not so spiky, same reading. So without structured monitoring, you don't know where things are, and you don't know where to approach things, either in lifestyle or in a medication review. So, HbA1c identifies hypoglycemia, very important, particularly as the patients get older. It identifies postprandial hyperglycemia, and it tells us about that dynamic relationship between all of that, insulin, carbohydrate, physical activity, and the resulting levels. It tells us in our patients the effect of different meals and snacks, the effect of their physical activity and exercise. So, we can go about the old traditional way. Now, I'm going to create a pun here. That looks like a dog's breakfast, and hopefully the breakfast this morning is a lot better. But there it is, the old-fashioned logbook. It's actually taken from the US, and the number's not in our language. But the compulsory blood stains there. But there are modern methods of doing that, and that's the Accu-Chek and the practice tools that come with Accu-Chek. And as you can see here, and I find the graph, this on the right, on your left side, very, very useful. Patients find that a very useful graphic. And then if you really want to still stick to non-computerized or not software, you've got your paper tool. Jane spoke about. Every one of you have got a paper tool on your tables. It works quite well too, so you don't need to necessarily do it on computer. I'm going to do 2 case studies. These are my patients, and they've been de-identified, and just to illustrate how we go through things. First case, we'll call him John, 78 years old. When I saw him for review, his HbA1c was 9%. That's a little bit about his past medical history, current medication. He had a mild dementia, but his carer, his wife, his carer, very, very, very good carer. And I think we mustn't forget about the carers, especially with our older patients. And they come in with the patient and they learn about structured monitoring as well. Obviously obese with a BMI of 34. So I, at that stage, said to him and to his carer, let's find out where the problem is. Now, he went away and we got him to do some structured monitoring. It was before Polanski's work, which brought out the 3-day snapshot. So we did it slightly differently, but it was still in a structured way. And reinforcing the motto of testing right frequency, right times, and the right situation. So now we look at how do we approach. Came back after a few weeks and came back with those readings. And there's an approach, actually, and it's a very nice little approach. AHH. First of all, look at A1C, then look at for hypos, and then look for hypers in that order. So we use that approach. As we said, his HbA1c is clearly not well controlled, 9%. We then looked for hypos. Well, there are no hypos there. And here we go. We've got the hyperglycemia. They're 2 different one. First one is the fasting hyperglycemia, and as you can see, it continues throughout the day, and obviously lunch was his main meal, and that became the most significant reading. So now we've got that result, we've got to ask why. And I always look at lifestyle first. This patient was of Philippine background. He loved rice. Rice was everything. And as you all know, when we talk about rice's portion size, and his portions were way over. So with the help of his very dedicated wife, we managed to persuade him to eat less rice and distribute it throughout the day. And at the same time, we did a little bit of medication changing, increased his Diabex and his Imicron, and we gave him a protocol of testing on alternate days. Slightly, again, different to, I would go now straight to a snapshot because that's the easiest. So, 3 months later, what happens? We look at the HbA1C, 7.8%. And we look at the graphs, and you can see his fasting is now within virtually normal range. Still has a slight peak post-breakfast and post-lunch, probably a little bit around dinner time too. And 6 months later, 7.4%, which I think for a patient of his age is absolutely fine. He's happy, I'm happy, his wife's happy. And that's our first case. So, benefits, once again, identifies timing and the frequency of the problem area. It helps us identify causes. In this case, it was a carbohydrate issue. It helps us facilitate and identify treatment options, and definitely encourages better patient engagement and understanding. I'll just go on to a second case, which is also an interesting case. A 65-year-old male, type 2 diabetic for 3 years. This patient, again, it's going back a few years, and it was before the introduction of the DPP-4s. He was unable to tolerate metformin, so we had approached our management with diet, exercise, and some Diamicron once again. I don't know if I gave his weight, but he was an obese patient. I haven't got his BMI here. He was certainly well over 30. And when you look at it, on the 8th of the 9th, 2009, his HbA1c wasn't too bad, 7.4. But if you look at his, and that's what I wanted to illustrate. If you just look at the, I'll have to get this pointer right. If you look, oopsie, oh, that wasn't a clever one. Wait a minute, oopsie, there we go. Okay. That is the issue. If you hadn't done self-monitoring or structured self-monitoring, you probably would have said, I would have probably said, or someone who's not doing it, well, at 7.4, you're almost there. You know, don't have to do anything more. But that came up, and I said to him, it's very interesting. You're doing so well during the day, and after dinner, you go up. And then he smiled. And I said, why are you smiling? He said, I love ice cream. Every night, religiously, 7 days a week, he would have a nice serving of ice cream. So we did a little bit of dietary intervention, told him he could have ice cream once a week if he was behaving himself, but we changed it to one piece of fruit, and I said, look, how about we do a little bit more walking? And 3 months later, HbA1c 5.9%, and a very nice curve. This is a busy slide. And I'm happy for you people to, I wrote this as a resource some years ago, and Roche will be happy to pass this on and how you can organize your practice with self-monitoring. Being a solo GP, my patients arrived 15 minutes earlier. My receptionists are excellent. They download the meters, put it onto the, we have a special Accu-Chek file, and then they self-import it into the patient's notes, and I'm going to demonstrate that to you in a moment. When you use, and this relates obviously to the software, when one uses the Accu-Chek 360, which is my favorite, and it's the most modern of the Accu-Chek generation, there we have indicated with the arrow. Let's hope we don't make a mistake this time. That little icon allows you to do a few things. You can fax the result, you can email the result, although you've got to be careful now with privacy regulations. And you can also save it to a dedicated file, which you set up when you set up your software. And I usually do that. I export all the results into that file and then re-import it. I use best practice, re-import it into the patient's notes, and I'll show you that now. So when you select a report, you choose which report, and for me, the standard day report is the most useful. And there are the options as I spoke. The last option, which is a fairly new option that's come onto the software, is exporting it as a PDF. That's my documents library there, the Accu-Chek patients. And it's useful because you can, from time to time, you can actually go into that folder, apart from looking at your own patient software, and see how you've gone over the years. And that's what it looks like. This is best practice, importing it back into correspondence in. And this particular patient is very keen. There we go, over the years. And that's what the documents are. All my Accu-Chek patient results. And I think you asked me about how big are those files. Well, they're not too, well, they vary. I suppose that maybe some people, doctors don't like large files because of the graphics. My answer to that, I think it's the way that I do it is very illustrative to myself and to the patient. And I don't worry about gigabytes because every few months systems are improving, and we upgrade my computer every 18 months and you just add more gigabytes. Finally, I just thought I'd have to do my own research. This is not a fancy research, but this is in-house research. So I looked at 25 patients who were performing regular SMG, and a period range from 12 to 30 months, and lifestyle, therapeutic, and therapeutic intervention. And I thought, well, what did I achieve? Before we started structured monitoring, 8%. After monitoring, 7.25. So that's not too bad. 0.75%, which is over that 0.5%. So I was quite happy. Okay, thank you. You just want me to stand here? Or? Yeah, actually. Come down.
We'd probably have time for a couple of questions. So is there a microphone around if you would like to grab the microphone or stand up and ask Jane or Hilton any questions?
Choosing wisely, pardon my ignorance, but can you give me a bit more information about choosing wisely?
Choosing wisely has come from the US. About 2 years ago, a whole set of recommendations were made in the US, and it's all about rationalising healthcare and making sure that we're spending health dollars wisely. And this is an initiative that's now come to Australia. As I said, diabetes was just one recommendation, and that was the only recommendation around diabetes that I showed you. Others are around all sorts of other aspects of healthcare. And on this one diabetes recommendation, they liaised with the RAC GP and came up with this recommendation about this. And just in the BBC News for the UK this week, Choosing Wisely has just started there as well, and they'll have recommendations by the end of the year. So it's kind of an initiative that's moving around the world, trying to come up with local recommendations that suit local health systems to improve and rationalise the spending in health. Do you want to say anything else about that?
Yeah, it's actually just hot off the press. It came out, I think, in the first week in May. A lot of it goes to choosing wisely in general practice in terms of investigations. So, a patient who's mid-30s has got backache, don't send them for an X-ray. I mean, unless they've got real obvious red flag symptoms. That goes along with pathology requesting, so patients get tested for vitamin D every 2 months. It's crazy. So there are some good points out of it, but unfortunately the glucose strips got caught up with it. It's an initiative by NPS, and NPS was fairly active in the days of divisions and Medicare locals, especially with divisions. And all you guys who work in practice will know that every 3 months there is a topic. So this last topic I got, the antibiotics you use in upper respiratory infections. Well, I don't understand how they get that. And they can understand what antibiotics I'm prescribing, but how do they know that I prescribed amoxil for, otitis media or for something totally different? So, and there's a lot of cynicism, I have to say, in general practice land against NPS because it's government funded. So unfortunately, if they want to make impact, I think they're tarred with a brush at the moment. But if you go through their recommendations, there's a lot of things there that are relevant. And
And are we able to get the slides?
Yeah, pleasure. Are you happy? If you want to help at any time, get hold of Roche, and I'm happy to take on the phone if you're having any issues with software. It's not a big deal. A lot of my colleagues are nervous about putting another type of software on their system. But it's a standalone, and the fact that it's standalone means you've got to manually import, but it's really easy. If you do it the way I've suggested, it's really easy. And if you got a lot, and I'm sure, like all practices, you've got lots of diabetics, and if you keep their graphs and keep it in their clinical notes, you can go to the patient and say, it's 2015 now, look, this is your graph today, it's done so well, look what you were like 2 years ago. And then it's encouragement. And diabetic, all patients want to be encouraged. They feel they walk out well. And I have a little game with them. I sometimes print it off, not a colour printer, and I've got these lovely stickers, well done, and all things like that.
So just one more question. We've got... Yep.
I just want to say that I was part of that Step It Up study, which is really nice to see the results after all this time.
Thank you for all your hard work.
I feel very privileged that I'm actually sitting here and listening to the results today. And I have to say that I still use the Accu-Chek download, and we have medical directors, so it
Works well, yeah.
Medical directors
It'll work with all.
exactly the same system.
Yeah.
And Roche have supported me tremendously over the last couple of years. So I just really want to say thank you for showing me the results.
Oh, thank you.
I vouch everything that the doctor has said I support as well.
Thank you.
Oh,
There's one more question.
so one more question was...
I was just wondering if it's available for download for the patients, if they're quite...
Yeah, they can. So I have got one or two. I think, look, there'll be a certain... The problem with that is that they go the other way. Usually people who want to download are fairly obsessive patients, and then they go absolutely crazy. And I've got one of those patients. He's a computer engineer.
Oh, yes.
And
Numbers man.
absolutely, numbers man. And he's asked me, he said, can I get this? I said, no, it's really not nice for patients. Because I know what will happen. He's done extremely well. And he loves it. He just loves the stuff.
But doesn't that just show you that it's really a useful way of engaging people, and particularly men in their own healthcare? There's stuff that they can do here,
Yes,
and technical things to look at, and gadgets to play with.
Absolutely.
It's great.
Okay, I think that concludes this morning. I really would like to thank Jane and Hilton for their time this morning, for an excellent presentation. I think the key message is it's achievable in all of your practices to adopt this, and there's a lot of evidence that it's made significant improvements. On behalf of APNA, I'd like to give Hilton and Jane a small token of our appreciation for their presentation this morning. And also, I'd like to thank Roche for putting on this fantastic breakfast. It was delicious. So we've just, Nicole would like to just have a quick word.
On behalf of the team of Roche Diagnostics Diabetes Care, I wanted to thank you all very much for giving us your time this morning and taking the time to listen to Hilton and Shapiro. I'm sure you agree it was very informative and very helpful.